all blue. All right, so it should be going now, right? Okay, very good. So embryology, anatomy, physiology, histology, and pathology of the breast. Basically, the breast is a modified sweat gland. I mean, the term we use for that is sudoriferous gland, but I think sweat gland is easier to say. Development begins for both male and female fetuses during the 6th week of embryonic life. It develops from the ectoderm, which is thickened along the milk lines, which actually run in mammals from the axilla to the groin. Epithelial cells at any point along this milk line have the potential to develop into mammary glands. Therefore, why other mammals, other than humans, have nipples going all down that milk line, as opposed to humans, which you only have, a pair of nipples usually. Both men and women can have what's called supernumerary nipples or breasts, which means that it's located in other sites along the milk line. You get extra nipples or extra breast tissue. And it's usually of no consequence other than you need to be aware that patients can actually develop lesions at those sites that are related to breast tissue. Normal breast development at birth is it's undeveloped breast tissue, and it's the same for both male and female infants at birth. Now, when hormones start circulating during puberty and adolescence is when things change, obviously. And it really all depends upon estrogen and progesterone stimulation. And where does that come from? Well, the development of the ovaries in the female, right? That's what's going to help release the estrogen and progesterone. Now, first, the breast tissue the ductal systems are, because, the breast, as you'll see in just a moment, is made up of a complex ductal system with alveolar proliferation at the ends of the ducts, kind of like the branches of a tree, and it's kind of like the alveoli are kind of like the leaves at the end of the branch, and that's where all the secretory cells are. So both the ductal and the alveolar system, or the secretory portion, respond differently to the hormones. The ducts respond mostly to estrogen, and the alveoli, or the secretory component, responds mostly to progesterone stimulation. But first, the ductal system matures, you get fat deposition. In fact, the breast tissue is made up of mostly fat, basically, fat surrounding the ducts and the alveoli and the lobular units that make up the alveolar system. The areola and the nipple show growth and pigmentation. Again, that's all due to estrogen. Now, as soon as progesterone starts to increase, it will stimulate those secretory components, the alveoli, that make up the lobules in the breast. You're going to hear ductal and you're going to hear lobule. And basically, and we'll see more of that in just a moment. And again, there continues to be fat deposition with increasing size of the breast, which occurs gradually. Now, here's an example from Netter that shows you the patterns of stimulation. Again, this is actually an ovary up here with a follicle. Remember that from the female genital tract? You've got a corpus luteum that's forming here, and that's yellow because the yellow, when it gets to that stage, it's forming what mostly? What hormone mostly? When it gets this luteinized appearance, it forms mostly progesterone, right? Remember, the luteinization occurs in the second half of the cycle. That's the luteal phase, right? So you got your estrogen stimulation, you've got your progesterone, you continue to have some estrogen stimulation during that part of the cycle too. And then, of course, this is your albicans, which indicates a corpus that's undergoing degeneration and scar tissue formation. But again, this is just to show you how the breast tissue during puberty responds to this development. And first you get, male and females both have ducts, okay? You have ducts in your subareolar nipple area. What you don't have as a male are lobules, okay? Lobules are unique to the female anatomy, okay? But both male and female throughout life have ducts. Now, the ducts in the female are going to be more developed and more complex, more branching, etc. And that's all due to estrogen stimulation. Now, here's an example of the ducts developing with the tiny secretory units or lobules at the very ends of those ducts, at the terminal portions of those ducts. And here are the lobules when they respond to progesterone stimulation, which causes the acini or the secretory units to proliferate. And so you get more of them, they get larger, and again, and here's the ducts right here. So ducts, lobules, where you have all your secretory units. Now the breasts, just general anatomy, the breasts lie over the pectoral muscles and are attached by a layer of connective tissue or fascia. Again, estrogen and progesterone control development during puberty. And as I've already mentioned, estrogen stimulates the ducts, progesterone stimulates the development of the alveoli or the secretory cells that line those alveoli or acini. They're glandular elements. The breast size is determined basically by the amount of fat around the glandular tissue, not by the glandular tissue itself. With the exception of during pregnancy and lactation, the glandular, during that period, the glands and the secretory elements tend to proliferate even more during pregnancy and lactation, and so then the breast size will get bigger because of that development. But outside of pregnancy and lactation, breast size is primarily determined by the amount of fat. And size does not relate to function, okay? And small breasts, large breasts, all can function the same. In general, breasts are composed of 15 to 20 lobes, kind of like 15, you can think of it as like 15 to 20 branching trees, okay, that are separate from each other. They all have their own systems. The lobe consists of a lactiferous gland, the main secretory duct, with a lot of surrounding fiber-connective tissue, and stroma that often has fat in it. Some of the excretory ducts connect, and all glands, including the small mucus glands, extend to the surface of the nipple. So each lobe is, has a main excretory duct or main lactiferous duct, which will extend to the surface of the nipple. And these, the main ducts all converge towards the nipple like the spokes of a wheel, basically. Now, the terminal ductules and acini, which are at the most, terminal portion of that, kind of like the branches and the leaves of the tree again, constitute with their surrounding supporting fiber connective tissue, constitute a lobule, which is the basic structural unit of the breast, the lobule. Because within the lobule is where you're going to find the smallest terminal ductules and the secretory acini. And now the secretory acini are the ones that, form the secretory material that will then go into the terminal ducts and then ductules and outside into the larger ducts and eventually towards the nipple. All right, so let's look at this a little bit more. Each of these lobes and each of these lobules are separated by fibroconnective tissue, which also contains some fat. Again, this is looking at the breast from the anterior aspect, having removed the skin and the overlying subcutaneous soft tissues, and then looking at how as you can see right here, you have your main excretory ducts that are also called lactiferous ducts. Basically, here you are, lactiferous ducts that are immediately beneath the nipple. Their openings connect with the nipple openings. Beneath the lactiferous ducts is a little sinus, a little dilated area called the lactiferous sinus. And then again, each of these, kind of like the trunk of a tree, okay, branch out into individual lobes. So each of these are individual lobes. And again, there's anywhere from 15 to 20 per breast. And you can see that there's some ligaments and fiber connective tissues separating each of these lobes. That's represented by the white tissue here, and you can see a little bit here too. And then you have your secretory units in here, which contain multiple lobules surrounded by connective tissue. Within the lobules are terminal ductules, the smallest ductular unit, with the acini, which are your secretory units. Again, you can see the muscle, this being the pectoralis major, serraceous anterior, external oblique muscles that the breast tissue sits on. Here it is on the sagittal section. This is actually the chest wall, showing you ribs on cross section, your first rib here, your clavicle here, and so forth, sixth rib down here. The muscle, you have muscles both between the ribs as well as, the pectoralis major is represented here. And then, of course, your breast tissue, The yellow represents fatty tissue. You can see that most of the breast tissue is actually fatty tissue. The white representing the connective tissue. The pink representing the breast parenchyma. Now the breast parenchyma includes both the terminal ductals and the acinar units. There's multiple lobules within each of these sections here. Again, you've got your main ducts coming from each lobe, your lactiferous duct, your lactiferous sinus, and of course the cross-section of your nipple here. There are some ligaments that help to support the breast tissue. They're called suspensory ligaments that are scattered throughout the breast, also known as ligaments of Cooper, and they help provide support. Again, when a woman has a mastectomy, which by the way, they don't do many mastectomies nowadays, they try to avoid doing as much because you don't need that. Most women can have more conservative surgery for their breast cancers now, and so mostly lumpectomies are done, which includes a whole section of breast tissue. But when a mastectomy is done, obviously they go down right to this pectoralis fascia here, just right along here to remove the breast tissue. They don't remove the muscle. The muscle stays intact with a simple mastectomy. Now, when they used to do radical mastectomies that they don't do anymore, you'll hear about that in your terminologies. Radical mastectomy, that would mean taking part of the muscle too. Now, nowadays, when women actually present with a large breast cancer in their breast, which may be involving the pectoralis muscle, which they can tell by doing MRI scans and mostly by MRI, you can tell that. What they'll do instead of doing radical mastectomies, because that's a very aggressive surgical procedure, they'll treat with chemo first, and then the tumor will actually, in most cases, will shrink in size to the point where they can actually do a simple mastectomy instead. The goal is to try and keep this surgery as less extensive as, keep the surgery to the extent that's needed for treatment and not have to take as much tissue. And here's another side view of the breast, again showing you the muscle, the adipose tissue, the ducts, and the lobules. Okay, now each of these lobular units here that make up a given lobe is filled with multiple tiny microscopic lobular units that we're going to see on histology in just a moment. All right, so the size of a lobule varies. It actually depends upon hormonal function mostly. It's largest during young womanhood. It contains numerous ducts. After menopause, the lobules, you get atrophy of the breast tissue, and the lobules start to decrease in size and may be composed of only a few ducts. The secretory duct of each lobe leads into a separate duct system that doesn't communicate with the neighboring lobes. It's separated by that fiber-connective tissue. And this singular existence is very important in the localization of lesions that occur in the breast when secretions arise from a single pore, which sometimes happens. In other words, you've got one lactiferous duct going to you've got 15 or 20 lactiferous ducts that go to the nipple surface. And if you have secretion from only one of those ducts, you can help the surgeon and the radiologist localize where a lesion is by knowing that. It also makes a difference in how surgeons do their lumpectomy specimens, because generally they're going to take several lobes from one area depending on how big the lesion is when they do lumpectomy. So it's very important to understand that anatomy, mostly for treatment and diagnosis. Now, let's look at some of the anatomy a little bit more detail. The nipple is a raised structure surrounded by the areola, which contains numerous ducts and mucus glands, which open to the surface. A short distance beneath the orifice of the nipple, in other words, the opening of the ducts onto the nipple surface, the ducts form a dilated area called here it's mentioned it's called the ampulla, but it's also can be called the sinus. Those are equivalent terms, okay? So you'll hear the name lactiferous sinus, or you hear the name ampulla, or they're all similar. It's just a small little dilated area. And it's supposedly like a small reservoir, and I guess it's useful during lactation. The areola is a circular pigmented area that surrounds the nipple which contains sebaceous glands. And the sebaceous glands are like sebaceous glands anywhere else on the skin surface, but on the breast we call them, and they're just more numerous on the nipple, and on the areola, they're much more numerous. They're referred to as the glands of Montgomery. And they can appear as small nodules under the surface of the areola skin. Now, the areola nipple histologically looks like skin elsewhere in the body. It's composed of keratinized, stratified squamous epithelium, just like elsewhere on the skin, except again, it has the ducts, it has the increased numbers of sebaceous glands, and it has pigmentation. The ductal orifice varies depending on how far you are into the breast tissue. Right at the surface, the ductal orifice is lined by stratified squamous epithelium, just like on the skin surface. And so again, some of that stratified squamous epithelium that's keratinized lines that orifice for a small distance, and eventually it becomes glandular type epithelium. Because what are ducts lined by? Glandular epithelium. So, and the lactiferous ducts, the secretory ducts, the smallest ductules, the terminal ductules, and the acini are lined by a variety of cuboidal to columnar glandular epithelium. And again, the size of these cells, the function, the morphology will vary according to the degree of hormonal stimulation and the function of the breast. Here's some examples of the nipple, looking at it in a kind of a longitudinal section here. So here's the surface up here of the nipple, and this is going down into the breast tissue just beneath the nipple, the subareola, or just beneath the nipple. And then here is one on cross section. So this is actually a nipple taken in a cross section cut and then embedded so that you can actually see the lactiferous ducts on end. Here you actually see the lactiferous ducts kind of going longitudinally in this tissue. But on the surface here, you see that there's stratified squamous epithelium that is keratinized. It's hard to see from this distance, but just trust me on this one, it is keratinized. Beneath it, you see all this kind of nodules of white tissue, whitish tissue, pinkish white tissue on each and each. These are actually the sebaceous glands, and you can see that there's quite a bit of them. This is actually a hair follicle here. Yes, there are some hairs on the nipple and the areola. And down here, again, are your largest lactiferous ducts, the ones that are actually leading to the surface and have openings out to the surface of the nipple here. Now, you don't see that here because it's based on, it depends on how you take the section of tissue. You're not going to always see the opening of the ducts on the surface, but they do. They all connect. Each of these connect to the surface. And again, you see them here on cross section. Here's the skin on the outer, or the epithelium of the nipple on the outer side here. And then each of these spaces here represents a cross section of the opening of a lactiferous duct as it's going towards the orifice of the nipple. Now, secretory activity generally decreases from the acinus to the ductal orifice. So most of the secretory activity is in the acinar units that make up the smallest lobule, histologic lobule. But again, the epithelium is going to vary from columnar to cuboidal depending on its function. Now, those acinar units that are very secretory active, have a lot of secretory activity going on, such as lactation, pregnancy, for instance, the epithelium is going to be much more abundant. Okay, and we're going to see examples of that in a little bit. But in general, the more active the cell is, the more secretions that are being formed, it's generally going to be a larger cell with more columnar appearance to the epithelium. Now, the ducts are lined by columnar epithelium as well, but they tend to be, the columnar epithelium tends to be more pronounced in the largest ducts, whereas the smaller terminal ducts have more of a cuboidal type epithelium. Okay, so smaller ducts, smaller cells, larger ducts, a little bit larger cells. Now again, here's some normal breast tissue on histology. This is looking at several lobules making up a larger lobular unit that makes up, part of a lobe in the breast. This is looking at the smallest lobular units. This structure right here is a what? Anyone? What do you think that is? We've been looking at some examples already. This whole thing right here is a lobule right here. That is one lobule. This is a duct, okay? The ducts tend to have that, opening, because that's where all the secretory material is going into. So this is a duct right here. This is a duct. There's several smaller ducts that are coming off of it. This whole thing right here is a lobular unit. This is a lobule. This is a lobule. This is a lobule. So each of these, these rounder, structures composed of these smaller glands, each of these is a single microscopic lobular unit. Now, within a given lobular unit are acinar elements, and each of these right here are acinar units that make up, the secretory element of the lobule. Now, there's also terminal ducts within this lobule because, how does the secretory material get to this larger duct? Okay, it has to go through the duct system. So the ducts start in here, but they're really tiny. They're called the terminal ductules. Okay, those are the smallest ductal units that are usually lined by cuboidal epithelium. So you've got your acinar units, your terminal ducts, and then your duct right here. Okay, and again, you've got multiple acinar units, or alveoli that they're sometimes called, within a given microscopic lobule. Now, one of the things to be aware of on histology, and you're going to learn a lot about this cell, and you're going to see this a lot, and it's going to be very helpful in cytology as well, is that each of the acini and the ducts throughout the breast tissue, I'm trying to go backwards here, here we go. Each of these elements here, each of these is lined by myoepithelial cells. Okay, myoepithelial cells contain myofilaments that are contractile. So that's how the secretory material gets moved along the alveolar, through the lobules, into the terminal ducts, into the ducts. The myoepithelial cells are very important for allowing that the secretory material to go out of the breast for its functional purposes. So myoepithelial cells are very important, and we see that in normal breast tissue always. Now again, you saw that a lot of the tissue surrounding these lobular units here, all of this pink, right here, pink, and then a little bit of white here and there. The pink is a fiber connective tissue, and the white is some fatty tissue. There's not as much fatty tissue on this particular section, but you'll see it in other areas. But this is all fiber connective tissues, and with vessels, tiny capillaries, throughout the breast tissue surrounding the lobular units. And actually within the lobular units too, you can see that there's always some supporting fiber connective tissue. All right, so let's look at this a little bit higher power. Here's a normal breast duct. It's lined by columnar epithelial cells. There's one or two layers of the columnar epithelial cells, and was surrounded by, at the periphery, myoepithelial cells. The myoeps are actually a little bit smaller, more oval in shape. These could be the nuclei of some myoeps that I'm pointing at right now. The rest of and again, you see them scattered around the ducts. Now, this particular duct happens to be a little bit dilated and filled with some foam cells. Now, you'll learn later what foam cells are all about, but just for purposes right now, I'm just going to mention they're very similar. They're macrophages basically that are present within the lumen of the duct. Here's another duct. Again, this is on higher power still to give you more of a close-up view. And again, what we see here are columnar epithelial cells, 1 to 2 layers thick. It's okay to have look like there's 2 layers here. That's normal. And then you see and you can see the columnar shape of these glandular cells, very nice. They also tend to occasionally have what looks like little secretory caps, on them. And that's just the cytoplasm can do that sometimes. That's typical of secretory type cells to do that. And then if you see these round, the smaller cells at the base here, they have more of a round to oval appearance to their nuclei with cytoplasm that looks a little vacuolated. Those are the myoepithelial cells that are surrounding the ducts, again, to help that contractile function of moving the secretions as needed. All right, so again, here's another example. There's two, one whole one and one partial one, breast lobule here. Some people refer to them as the terminal duct lobular unit. You'll hear this, and sometimes we abbreviate it as TDLU, just so you, if you ever hear that term, okay, it stands for terminal duct lobular unit. Now, all that's doing is telling you that within this given lobule is terminal ducts and acini, basically, that make up the functioning breast tissue. And again, you see multiple acinar structures here that are round and regular. They look a little bit elongated just because of the way it's cross-section on the tissue section. And then of course you have your terminal ducts that lead out of the lobular unit. Here's another schematic representation of the components of the breast tissue. Again, you're hearing this over and over again. Here's a given lobule composed of round secretory or acinar units. Here's a terminal duct, and you have parts of it in the lobule as well because they start at the acinus. And as you go up into the larger ducts here, you can see that the lining cells are more cuboidal, a little bit flattened. As we get into the largest lactiferous ducts, it starts to become more columnar as it goes towards the nipple, because that's where you see the largest lactiferous ducts towards the nipple. And now this is showing you the myoepithelial cells that surround the ducts, and they surround the acinar units, individual acinar units and lobules as well. A couple other things to be important to understand for the anatomy is of the breast tissue. Any questions on the lobular unit? Because it's important to understand that, to understand the pathology. Okay. Lymphatic drainage, there's two main sets of lymphatic drainage. There are lymphatics that originate and drain the skin over the breast, and then there's lymphatics that also originate and drain the breast parenchyma. When you hear the word breast parenchyma, it's referring to the ductular and lobular units of the breast, as well as the areola and the nipple. There are superficial and deep lymphatic vessels that communicate with the lymphatics in the fascia of the pectoralis major muscle. And generally when they do radical mastectomies, they remove part of that, and which they hardly do anymore, as I mentioned earlier. They'll remove a wide area of the deep fascia, as well as a lot of the lymphatics that are in that area. Now, lymph nodes associated with the breast, about 85% of the lymphatic from the breast enters into the axillary lymph nodes. So you hear about that a lot in breast cancer patients. They always got to get their axillary nodes. Whenever a patient is diagnosed with breast cancer, one of the first things they're going to look at is the status of their axillary lymph nodes. You know, because that makes a difference in staging and how the patient is treated. It's always good if the axillary nodes are negative, but 20 to 25% of breast cancers, when they present, will have involvement of axillary lymph nodes, which automatically bumps it up to a stage 2 breast cancer if you have involvement of the lymph nodes, if other things are, and we'll talk about staging a little bit later. So where does most of the lymph drain from the breast? To the axillary lymph nodes. But there are actually other places, and there's probably about 40 lymph nodes in the axilla, at least, okay? When we get surgical specimens for breast cancer patients where they've actually had a complete axillary dissection for breast cancer, we want to find at least 20 lymph nodes, okay? That's there's actually a recommendation from surgical societies as well as pathology societies that you should find at least 20 lymph nodes in an axillary node dissection. There's usually more than that. Some of them are microscopic and you can't actually see them when you gross the specimen. And so just think about that. There's at least going to be 20 nodes in the axilla when they do an axillary node dissection, because sometimes they don't take out. Nowadays, the goal is more conservative surgical approaches, and that means actually only taking 1 or 2 nodes as necessary. They don't often do complete axillary node dissections nowadays, unless it's positive, okay? Because think about it. I know I'm jumping ahead a little bit here, but it kind of explains about the axillary nodes a little bit. Breast cancer patients, they only present with, I said, about 20% of them present with mets to the axilla. 80% of breast cancer patients do not have mets to the axilla. So do you want to take out the complete axilla in every patient with breast cancer? No, because there's not as many with positive nodes. So nowadays they've come up with procedures called, you've probably heard of it, sentinel node biopsies. Does that sound familiar? No? Kind of? Well, sentinel node is the first lymph node in the axilla or in the internal mammary area, which is where lymph nodes can also be, but most of them occur in the axilla. Sentinel node is the first draining lymph node from the breast, and they can determine that by injecting dye preoperatively, and then watching where the dye goes to. And they have all these special imaging devices that both the surgeons and the radiologists use to try and detect that quote-unquote sentinel node. So nowadays they find out if you take the sentinel axillary node and it's negative, then you don't have to do anything else with the axilla. But if it's positive, then they're going to have to go in and do a complete axillary node dissection. And that's important because if a woman gets a complete axillary node dissection, they take out all that nodal tissue and soft tissue in the axilla. It actually can cause side effects, problems in the future of proper lymphatic drainage from your arm. So it's important, you don't want to have to live with that side effect if you don't have to. So anyways, the lymph nodes, most of them are in the axilla. There is what's called an axillary tail ascens, which is an axillary extension of breast tissue, where you don't want to confuse that breast tissue with lymph node tissue. Okay? All it means is a little extension of the breast in the upper outer quadrant and in contact with some of the axillary lymph nodes. Now again, there's some other lymphatic channels where the lymph will drain into the parasternal nodes, also called which is along the sternal border. It's called the internal mammary chain. And sometimes the surgeons will, if they do the pre-surgical studies that they usually do, they'll be able to detect whether or not there's involvement of those internal mammary chain lymph nodes, and they'll be able to go and sample those as needed. All right, so here's the lymph nodes. As I was already mentioned to you, here's the axilla right here, and you can see that there's a lot of lymph nodes in that area. Now, men have same number of axillary nodes, okay? It's just that, you don't need them for draining your breast tissue, but probably they do drain other things from your arm or from the skin and on your chest wall. They're all there for draining different from lymphatic channels from around that area. Excuse me. And so you also have supraclavicular lymph nodes here. You have lymph nodes that go along the sternal border here. That's your internal mammary chain right here. Excuse me a second. All right. So going on, a little bit about the function. We've already been talking about this a bit, but just to review some of the hormonal effects and physiology of the breast. Again, the breast can change. Obviously, it changes. We know it changes during puberty and adolescence, but it also can have changes during the menstrual cycle. During the proliferative phase of the menstrual cycle, the breasts are stimulated by estrogen. During the secretory phase, also known as the luteal phase, both progesterone and estrogen act on the tissue and produce ductular and acinar development with some secretory activity. Now, of course, this isn't being used for anything. There's no lactation going on them, and usually the secretory material that's formed during the menstrual cycles is reabsorbed by the tissues in the breast and by the macrophages that are always there. Pituitary prolactin appears to act directly on the breast to stimulate and regulate lactation. So you need that in order for lactation to occur. All right, so here's more examples. Again, you already saw this picture. This is the development of the breasts in response to estrogen and progesterone. Again, here's a review of the life cycle of the breast tissue. Infant breast is slightly prominent actually at birth due to the presence of circulating maternal hormones. And in fact, it's not uncommon for there to be nipple secretions right at birth for a few days. And it has this unfortunate term, witch's milk, okay, because it used to be something that was considered to be kind of, bad, I guess, but it's not. It's actually a normal thing. And it happens because of the sudden withdrawal of the baby's exposure to maternal hormones at birth. Again, this only lasts for a few days. And again, the breasts stay in an undeveloped state until, in both male and female, until obviously adolescence. And then you get gradual development of both the breast parenchyma and the stroma. At reproductive age is when you get the puberty. In other words, is when you get your greatest cyclic hormone influence. And again, at the same time is when menstrual cycles are beginning. And again, as menstrual cycles progress and form more and more hormones, then you get more and more development of the breast tissue. During pregnancy, the ducts become very proliferative, as do the secretory elements, okay, in response to a number of circulating hormones. The secretory elements will accumulate fat droplets and lots of secretory material as they prepare for the lactation. Immediately postpartum, the first secretion is referred to as a colostrum, and it's actually considered to be some of the healthiest food, milk, etc., that the baby can get in the newborn period. It tends to contain a lot of antibodies, a lot of other protective substances for the baby. And what occurs is a lot of holocrine secretion. You get fat-laden epithelial cells shed into the colostrum. It's a thin, cloudy fluid secreted a few days before true milk is formed. But again, colostrum is very, very good for the baby for a number of reasons. During the postmenopausal period, there's gradual atrophy of the breast tissue with regression and involution of both the ductals/tubules, but the tissue still remains sensitive and responsive to hormones, Lactation is the main function of the breast. All other discharge from the nipple is abnormal. Okay, there should never be any discharge from the nipple unless there's lactation taking place. So any discharge always deserves a outside of lactation period should be checked out in a woman. What is the mechanism? Basic mechanisms, physiologic mechanism of lactation? Well, estrogen promotes breast development and inhibits the anterior pituitary secretion of prolactin during, pregnancy. But as soon as the baby is born and suckling occurs, it stimulates the production of prolactin and the posterior pituitary secretion of oxytocin. And the prolactin is what then stimulates lactation, increases the secretion of the alveolar units within the lobule. And the oxytocin helps to stimulate the alveoli and the myoepithelial cells surrounding the alveoli, okay, to help eject the milk into the ducts. So both prolactin and oxytocin are important for this function. And here's a picture here showing you the during pregnancy and during lactation. And again, the breast tissue is already showing hypersecretory activity during pregnancy, but it's not going to show evidence for lactation until the proper hormonal environment is present, to include the presence of prolactin and oxytocin, which forms after the baby starts sucking on the nipple. And then, but again, notice how this is a lobule. Remember what our lobules looked like before? Okay, you can see how the acinar units have become quite proliferative during both pregnancy and lactation. Here's a duct here. Okay, so the lobules have become larger. They have more acinar units. The individual cells that line the acinar units also become larger because, again, they're undergoing very pronounced secretory activity. Here is in lactation, you actually see the alveolar units dilated and filled with secretory material, which is what makes up the milk. Here's an example on H&E histology of the lactating breast lobular unit. This is one lobule. And you can see there's some terminal ducts within it as well, which you would expect. But notice how large and proliferative these are compared to the normal lobule. There's many more acinar units. You can see the pink secretory material in there that represents the milk. And again, and when you look at the individual cells, even the cells are larger and have lots of fatty vacuoles in them, like you see here. This is a higher power of a lobule that's showing lactation. And again, notice how the cells here are very large. This is one acinar unit. Here's another. Here's another. They have abundant cytoplasm that's vacuolated. You've got nuclei that are larger than normal. That's normal. You know, you expect very active cells are going to show larger nuclei. They also have nucleoli. You know, yes, they're undergoing a lot of activity. So there's going to be larger nuclei, prominent nucleoli. Again, lots of vacuoles in the cytoplasm. Those are fat vacuoles because there's a lot of fat within the milk secretion. And so this is a very lactating tissue. Okay, now, well, that's the basic histology and physiology. Are there any questions on that? Okay, now let's go on. We'll talk a little bit about some of the non-neoplastic conditions. This is just a schematic diagram showing you the various anatomic sites of some of the more common breast lesions. Some of the lesions that you'll see occur more often in certain areas of the breast. You know, for instance, the lactiferous sinus tends to, well, first let's begin at the nipple first. The nipple is where you'll see Paget's disease. We'll talk about that. You heard about Paget's disease in the vulvar area of the external female genital tract, but it also occurs on the nipple, okay? And that's where it can occur. Adenomas can occur in the largest lactiferous ducts and sinuses, and we call them nipple adenomas. Intraductal papillomas also tend to occur in the larger lactiferous ducts closer to the nipple. That's why they tend to be more common in the subareolar areas. The individual lobules here, you're going to see a number of things occur there. Benign fibroadenomas, fibrocystic disease, as well as cancer. Same thing with the terminal ducts, you're going to see cancer as well as hyperplasia. And we're going to look at each of these in some detail. All right, so beginning first with the benign, non-neoplastic disorders, which are actually the most common of all the pathology that occurs in the breast, thankfully, is benign and non-neoplastic. First of all, you can get inflammatory processes occurring in the breast just like anywhere else. Probably one of the most common to be aware of is acute mastitis, which is basically acute inflammation of the breast tissue, and usually involving the largest lactiferous ducts near the nipple. What causes that? Nursing. Okay, not everyone, not every woman who is nursing gets mastitis, but it is certainly not uncommon in that situation, and it's caused by the same types of bacteria that cause infections on the skin surface. Staphylococcal aureus as well as streptococci are the common bacterial organisms causing acute mastitis. Now, the thing about acute mastitis is that it's very tender, very inflamed. The breasts get very inflamed. In the healing process, some scar tissue can form. You don't want to, and sometimes that can pose a problem for whether or not that scar tissue represents a true breast mass, breast lesion. Sometimes needs to be evaluated. But in most cases, the acute mastitis will resolve with the appropriate antibiotic therapy. Okay, that's what it's needed. Mammary duct ectasia tends to occur in, I have to tell you right off the bat, this is an older term, but it's really a term we use nowadays to describe a certain histopathologic appearance. But you'll hear this term occasionally. It tends to, and you see this more often in older women, and ectasia is a word you'll see in other things. Basically, ectasia means dilation of a duct, okay? And so you see dilation of the ducts, you get some inspissated breast secretions in it, because the ducts aren't able to absorb it as well, so you get some inspissated breast secretions. And then because of this dilation, you get some inflammation and the inspissation of the secretions, you get some inflammation around these dilated ducts, mostly chronic inflammation, mostly lymphocytes and plasma cells, occasionally granulomas, where you get foreign body giant cells because of the some of the ducts become disrupted, and so the other tissue around the ducts will respond to some of the secretions that get outside those ducts. So again, the etiology is unknown, but it's again a type of chronic inflammatory response, basically to irregular dilated ducts. Okay, here's some examples from Netters, again showing you some of the clinical and anatomical pictures of these disorders. This is from an example of a very bad case of acute mastitis. Both breasts are very engorged, red. I dare say they'd probably be very painful. And you see the redness here, the swelling of the breasts, and this is showing an example of one that actually has all these cysts associated with the inflammation. This occurs in a chronic case of mastitis, so it's kind of like a chronic cystic mastitis it's turned into. Hopefully, the usual case of acute mastitis that occurs with nursing doesn't usually become this bad. Okay. All right, I'm showing you an FNA. Because what are you going to see with acute mastitis is tons of inflammatory cells. Okay, just like an acute infection anywhere else, it's basically purulent debris. So you see all this necro-inflammatory cellular components, and you got this necrosis in the background, you got all these acute inflammatory cells. You may see some capillaries, because what happens when you get lots of acute inflammation, you get vascular response to that. So again, typical acute inflammation. You don't see a lot of epithelium in this setting. And so when you see something that's like this on tissue or FNA, it's pretty diagnostic that this is most likely acute mastitis. And probably the first thing you want to think about doing when you get this on a breast FNA or touch prep of a core biopsy is, what would you like to do in that setting? You get something that looks like this. What are you going to want to do? You're the only cytotech on that cart. You're the only one there. There's no pathologist around. Okay. So what are you gonna want to do when you see all this acute inflammation? Besides make the cytology smears and check for adequacy and all that good stuff. Besides that, well, what is going to be the best thing to help treat that patient? That patient's going to need what kind of treatment? Antibiotics, right? So send a sample for culture. That's probably the best thing you can do. I'm sorry, maybe I wasn't being clear enough, but you definitely want to consider always trying to get a sample and sending it for culture, because the best thing for that patient is make sure, and culture and sensitivity, to make sure they're on the right antibiotics. Although there are pretty standard antibiotics for staph and strep infections, but sometimes it can be helpful. All right. So what about fat necrosis? That can occur. Remember, I told you the breast is composed of a lot of fatty tissue. So fat necrosis can occur, and it most commonly occurs because of some kind of trauma to the breast or repeated trauma. Like, say a woman is in a car accident and she hits her chest on the steering wheel. That can cause a lot of trauma, and that can cause trauma to the fatty tissue within the breast, and so you can get fat necrosis. The other thing is women who do a lot of hard impact type exercises and running, they don't have good support bras. That can also cause some form of fat necrosis too. But the important thing to know about fat necrosis clinically is that it can form a hard nodule in the breast when it heals, and also on mammogram studies it can look like a lesion of concern, a breast cancer. And so it can get mistaken for breast cancer because of how it presents clinically, because it's firm and it shows up as an unusual lesion on mammography. And so most often these lesions have to be evaluated to make sure they aren't breast cancer. And so, but what does it look like? Histologically, the disease presents as a central focus of necrotic fat surrounded by inflammatory cells, both chronic and acute, as well as lipid-laden macrophages. And in fact, sometimes it becomes hard to separate out the necrotic fat from the lipid-laden macrophages because they can look very similar. The areas of necrosis are eventually replaced by scar tissue, which can, sometimes cause a palpable nodule or a nodule on mammography that needs to be evaluated, as I mentioned, make sure it's not breast cancer. All right, so here's an example of fat necrosis. Here's a fat up here, and then you see this kind of fibrous tissue with inflammatory cells, some multinucleated giant cells. The fat, when it breaks down, can cause a granulomatous response. So it's not unusual to see some granulomas in that setting as well. Here's another example, and again what you have here is mostly foamy macrophages, which are actually gobbling up the fat that's undergone necrosis in this area, as well as some chronic inflammatory cells throughout. Now, silicone implants. Now, implants, you don't use silicone anymore. They're used, say, different saline types substances are used, but there used to be a number of silicone implants, and they still are around, and women still have some in place, and they can still cause problems. The silicone can cause if it leaks from the implant, which it can, over a long period of time, you can see some microscopic leaking or some outright, if the implant were to rupture from trauma or something, you'd get a lot of leaking, but there's always some microscopic leaking that can occur with these implants. When the silicone gets out, it kind of causes a foreign body giant cell reaction, granulomatous response, and that's something to be aware of, which can also cause some scar tissue in the long term. But here's an example of a type of mastitis related to silicone. First of all, you see what kind of cell here and here. They look like they're multinucleated giant cells. So you've got your multinucleated histiocytes there that are gobbling up the silicone material. Now, you're not going to be able to see the silicone. It's a very clear, refractile substance. But all of these spaces here are presumably used to have silicone in it. Okay, it's just we don't see it in the tissue processing. Kind of gets washed away during the tissue processing. So all you're going to see are these spaces with this, and if you focus up and down on it, and this is true on CYTO as well, you'll see some kind of very clear, slightly refractile substance. But in most cases, you're really not going to see it at all because it washes away during the formalin processing. But this is indicative of what looks like vacuoles is actually spaces where the silicone used to be, and that's true for all of this here. All of this. All right, so now we're going to go on to discuss the most common disorder of the breast. It's a benign disorder. So if you're ever asked a question, what is the most common lesion or pathology seen in the breast? It's both benign and malignant. Most common is fibrocystic changes. Okay, fibrocystic changes accounts for more than 50% of surgical operations of the breast. It occurs more commonly in younger patients, because it actually has an association with the hormonal status of the patient. It's frequently bilateral, in other words, both breasts are involved. It has actually been found that oral contraceptives can help in treating this disease, because oral contraceptives tend to regulate the hormonal status for a woman, tends to cause a better balance of estrogen and progesterone, which helps to alleviate some of the findings of fibrocystic change, because it's found that the reason it occurs is because of a hormonal imbalance of either excess estrogen or a deficiency of progesterone or combination. Now, fibrocystic changes is kind of like you can kind of gather what it is by just kind of seeing its word. You get fibrosis and you get cystic change. And where does that cystic change occur? In the ductules, in the lobules. Okay, you can get cysts, and the ducts are most commonly affected, but you can also get cystic change within the lobules because you've got smaller ducts there too. All right, so you've got cystic change with fibrosis surrounding those cysts. Now, the epithelial lining of the cyst is a ductal type lining. In some patients, you can get hyperplasia and atypia of that epithelial lining in patients with fibrocystic change. Now, the important thing is fibrocystic change can, because of the fibrosis surrounding the cyst or in the tissue adjacent to the ducts that have dilated, it can cause a scarring and a mass that has to be distinguished from cancer. Okay, so here's some examples. Now, the thing with fibrocystic change, it tends to occur throughout the breast, and the cysts that form are usually small. And when we feel a breast that has fibrocystic change, it has a characteristic kind of very small nodular appearance. In other words, not big nodules, but it kind of feels kind of grainy in a way. When you palpate the breast, you can feel tiny little nodules throughout. Kind of what it's trying to show you here. Here's the lateral section of a breast tissue with very extensive fibrocystic change. Now, here's the more normal breast tissue down here. Here's the tissue that's affected by fibrocystic change, and you can see that there's some scarring around this tissue that is forming cysts. See, these are all, we call these blue dome cysts, and they have that appearance on gross exam because of when the cyst dilates and has a venous pattern or a venous component to its surface, it will make it look a little blue. It's not because the fluid is blue, okay, but because of the vascularity surrounding the cyst, basically. Now, sometimes the fluid does look blue, I have to tell you, but not really. It's more of the fluid color when we aspirate cysts, it can vary anywhere from white to yellow, to greenish, brown, to red, if they become hemorrhagic. Not usually blue, though. Okay. And here it is on histology, and it shows you these are lobular units, but again, they don't look like the same kind of lobules we saw earlier, because look at the ducts here, they're dilated, and even the terminal ducts and acinar units are dilated, as you see here, and that they're surrounded by some increased connective tissue in the fibrostroma. Again, cysts, fibrous tissue, fibrocystic disease, right? Okay. Here's another example, again, showing you that hormonal effects are important here. This is an example of a solitary blue dome cyst. Again, it gets that color because of the color of the fibroconnective tissue that's surrounding that cystic structure that's kind of dilated and filled with fluid. Here it is on cross-section. This is a very extensive fibrocystic change. It doesn't always get this way, but usually in chronic conditions that have gone untreated, you can get cysts this large, okay, surrounded by abundant fibrous tissue. But in most cases, the cysts are much smaller than that. Okay, but this is just really highlighting how large they can get. Now again, fibrocystic change, we talk about, this is actually the preferred term. I mentioned fibrocystic disease as well, but that's because my training from 20 years ago is coming out. Okay, but actually the preferred terminology right now is fibrocystic change, because they really think it's because it's a spectrum of changes that occur in response to hormonal manifestations. Rather than it being a true disease, it's more of a change. And you'll see fibrocystic change in the setting of other disorders occurring at the same time in the breast. Again, it presents as increase in fibrostroma associated with dilation of ducts and formations of cysts, which vary in size. When the cysts get really large, they can be filled with a serous or serosanguinous turbid fluid, which can make them appear blue-domed, as I mentioned. Histologically, the cysts are lined by epithelium that's either cuboidal or columnar, which can sometimes show some stratification and apocrine metaplasia. That's a really key finding, that fibrocystic change, when the epithelium undergoes fibrocystic change, it often will show metaplasia to apocrine appearance. And that's one of the features of fibrocystic change that you're going to learn to recognize very well on cytology. Now, larger cysts may be actually denuded of their epithelium, or have the epithelial cells become so flattened They can't even see them anymore because of the size. The fluid has kind of caused the cells to be very flat. All right. Now there's different types of fibrocystic changes. You know, there's a simple type, and there's ones that are more proliferative when the epithelium becomes hyperplastic. Okay. The various histologic components, and you'll see this in cytology too. The various histologic components of fibrocystic change include cyst formation, which includes microcysts as well as larger macrocysts, fibrosis of the surrounding stroma, apocrine metaplasia of the lining epithelium within the cysts or the dilated ducts. There's inflammation outside the ducts, periductal chronic inflammation. You can see epithelial hyperplasia either in the duct or the lobule, and adenosis, which actually refers to where you get more acinar units within a given lobule, okay, than normal. So not only do the cells become individual cells become hyperplastic, but the lobules can look hyperplastic too. All right, so here's some examples on gross exam. This is a gross appearance of a blue dome cyst. It doesn't look that blue here, does it? Okay, because it really is kind of a loose term we use, but again, you've got this is the normal tissue surrounding it. You got a little bit of fibrosis, and then you got this large cyst that's probably filled with very clear fluid. You can basically treat these by FNA, sometimes by just removing the fluid, because it's the cyst that can sometimes cause discomfort. Here's an example of a more extensive fibrocystic change. And everywhere you look, there's cystic dilation. Okay, these are all cysts here filled with abundant cyst fluid, okay, in each of these. Even some calcifications up here. And then you've got some epithelium down here that looks rather proliferative, hyperplastic. Okay, but mostly cysts that are dilated, varying size cysts filled with a lot of fluid. Here's a higher power of some of these cysts. And now you notice here's a more columnar appearance to the epithelium. But notice this epithelium looks very pink and more abundant. This is actually apocrine metaplasia on histology. So again, this is a form of metaplasia where the columnar, the ductal epithelial cells, which are typically columnar to cuboidal, when they become cystic, it can undergo this metaplasia and have more abundant pink granular cytoplasm. Here's another example of apocrine metaplasia that's also become hyperplastic. Why do I say that? Because you've got all these little tiny, this is actually one enlarged cystically dilated, actually there's three here. There's 1, 2, 3 cystically dilated ducts that are lined by epithelium forming these micropapillary projections. It's much more proliferative than you see normally. And they're lined by these apocrine cells that are just composed of this abundant eosinophilic granular cytoplasm. Now again, I've been telling you about epithelial and ductal hyperplasia, and this is a typical process that can occur in the setting of fibrocystic change. The ducts, the epithelium becomes hyperplastic, and it can be either to a mild to a moderate degree. It can also become atypical, cytologically atypical, both on histology and cytology. And when it becomes atypical, we actually call it atypical ductal hyperplasia. And you'll see these terms in different forms. Now, again, the epithelium or ductal hyperplasia, the epithelial or ductal hyperplasia is sometimes lumped under the general category of proliferative breast disease. It can be mild, moderate, or florid, or atypical, depending on how the individual cells look. Mild and moderate are also referred to in general pathology as usual ductal hyperplasia, or UDH. Again, this is a feature that's accompanying fibrocystic change. And it's important to understand these differences because when it becomes atypical, it's not considered a pre-neoplastic condition, but it can be a precursor to the development of a low-grade DCIS. In other words, those patients who have ADH, or atypical ductal hyperplasia, are at increased risk for subsequent development of breast cancer, and so they need to be followed more closely. Now, what happens when the ducts become hyperplastic? Remember I told you earlier that the normal duct is lined by 1 or 2 layers of ductal epithelial cells? In this setting, in a mild hyperplasia, there's usually more than 2 layers of cells. In the more florid one, you tend to get masses of cells growing within the lumen, okay? And then with atypia is when you tend to get the individual cytologic atypia. But here's some examples. This is mild epithelial hyperplasia. The ducts are proliferative here, but they're also showing an increase of thickness in the number of epithelial layers within a given duct. Here's an example of florid hyperplasia, or moderate. And again, notice this is one duct right here. This is one duct. Here's a more normal duct over here, although this one, even this one has a little bit of hyperplasia to it. But this duct here is quite expanded by this proliferation of ductal epithelial cells. There's still myoeps around. It's still benign. It's not cancer. But again, this is just showing you how proliferative this hyperplasia can get. And here's one that's showing some atypia. And with the atypia, you get both atypical architecture as well as cytologic atypia. And again, this is actually can be very difficult to distinguish from in situ ductal carcinoma, which we'll talk about in the next part. Let's see, where are we here? And then I'll see where we can take a little. Let's go through these next few slides and we'll take a break, okay? You know, I've been talking about ductal hyperplasia. Well, guess what? Hyperplasia can also occur in the lobules. And you can get proliferation, and it can also be atypical. And you can get proliferation of both the terminal ducts and acini. And this is also, just like ADH, is also associated with increased risk of developing breast cancer. There's another form of a non-neoplastic condition that can occur in the setting of fibrocystic change, but is considered separate from it. If we get a breast tissue that has it, we call it separate from the fibrocystic change, but often they occur together. But what's happened here is, unlike fibrocystic change, the fibrosis becomes very pronounced and very hyalinized, giving it a sclerotic appearance, which will cause distortion of the terminal ducts and acini, really making them look quite bizarre in shapes. And again, it can often be mistaken for breast cancer, as you can imagine. But the important thing to know is that patients with a diagnosis of sclerosing adenosis are also at a slightly increased risk of developing subsequent breast cancer and may need to be followed more closely. Now here's an example of a typical lobular hyperplasia. It's showing you a lobule. Now remember I showed you some earlier where you see all the dilated ducts throughout it and dilated acinar units. Well, here you can see the individual acinar units, and you notice how they don't kind of have a lumen anymore. They've kind of lost that lumen within them. And instead, each individual acinar unit becomes proliferative within a given lobule. Okay, so you see it's you've got this proliferation of cells within each acinar unit. And that's an atypical thing. And eventually, this could potentially, this is kind of bordering on lobular carcinoma in situ, as you'll see later. But it's not to the same degree. I know you're looking at this. How do we make this distinction? Sometimes it's hard, okay, between atypia versus in situ carcinoma. It can be a challenge. Here's an example of sclerosing adenosis, and it's showing you this very dense fibrosis. Lots of calcifications. That's what all this blue is here, or bluish purple. That's very dense calcification. Now this is important because this calcification shows up on mammography, and generally it will show up as kind of suspicious calcifications on mammography, and that's why it gets biopsied, to make sure it's not cancer. Here's another example, very proliferative lobular units, and lots of fibrosis surrounding it. Now again, the reason we go through all of this is because it's important to understand that these different disorders actually have different risks for development of invasive breast cancer. Now, a patient with just simple fibrocystic change with simple or usual ductal hyperplasia has no increased risk, okay? And the other things listed here, which we see in association with fibrocystic change, as well as some other disorders, we haven't talked about fibroadenoma yet, but we talked about everything else. All of these things, when they're in breast tissue, that patient has no increased relative risk for development of invasive breast cancer. Whereas, if you have moderate ductal hyperplasia or sclerosing adenosis or papillomas, you have a slightly increased risk. If you have either ADH or ALH, you have moderately increased risk of 4 to 5 times. And patients with a diagnosis of in situ carcinomas, either lobular or ductal, have a high risk for subsequent development of invasive breast cancer. All right, so we'll go ahead and take a break now. When we come back, we'll talk, it'll just be a few minutes to talk about the benign breast tumors, and then we'll get to the malignant ones. All right, let's just break for about 10 minutes. We'll come back at 5 of. I guess we're going to go past your usual lunch period here right now, but they don't? No. Okay. Well, I'll see you back at 5 of then. Or should I pause it? Let's see. Where is it? Right here? Okay, just this one right here? Okay. All right. What, no? One more time. This one? Button. All right. So, test. Is it on? Can you hear it okay? Yeah? Okay. All right, some other benign. Now, this time we're going to look at the neoplastic conditions. And the benign breast neoplasms include the general categories of the following here: fibroadenoma, Phyllodi's tumor, the benign one, and then intraductal papilloma. Now, fibroadenoma, if you ever get questioned, what is the most common benign breast tumor? Okay, the answer is fibroadenoma. It is the third most common lesion of the breast, behind number 1, fibrocystic change, and number 2, breast cancer. Okay, so number 3 is fibroadenoma, if you're looking at all lesions affecting the breast. So this is very common. Most common before the age of 30, so again, young patients. It usually presents as a discrete, encapsulated, 2 to 4 centimeter, freely moving nodule in the breast. So that's unlike breast cancer, which tends to be kind of hard and fixated to the surrounding tissue. This one tends to be mobile. It tends to be seen most often in the upper outer quadrants. And histologically, you can kind of figure out from its name, again, what it is. It is what we call a biphasic tumor. Biphasic meaning it has a stromal component and an epithelial component. Okay? And so you've got this loosely cellular fibroblastic stroma enclosing benign glandular spaces that can sometimes be cystic. There's a couple of varieties. We don't normally make this distinction anymore, pericanalicular, intracanalicular. It's just how the fibrous tissue surrounds the proliferative epithelial component. Now here's an example of one being removed from the breast. Again, it's a discrete rubbery nodule that looks like this, kind of pinkish, very uniform, uncut surface. This is what it looks like on histology. You've got stroma surrounding these kind of dilated and irregularly shaped ducts that are lined by benign ductal epithelium. Sometimes this is actually a papilloma. This is a fibroadenoma. This is actually a papilloma occurring within a cystic space of the breast tissue. And we'll see that a little bit more in just a moment. Here's another example of a fixed breast with a very uniform, discrete nodule that has a kind of rubbery cut surface. Here it is on histology. Here's normal fatty tissue out here. fibrous capsule of pink tissue surrounding this tissue right here with this kind of, this is the stromal element, this is the epithelial component. You can see the stroma has proliferated and is causing some collapse and distortion of the ductular elements that are kind of scattered throughout. But again, this is all benign. Now, what about Phyllodes tumor? It's also a biphasic tumor with both stromal and epithelial elements, but it tends to be, in contrast to fibroadenomas, it tends to occur in older patients and tends to be and can be larger. Now, the other thing about Phyllodes tumors, there's both benign and malignant forms. The old term for the malignant forms that you'll still see occasionally in the books is, and in your text material here, is cystosarcoma Phyllodes. That's just a malignant variety, but there are definitely benign varieties of, when it's just a plain Phyllodes tumor, you got to ask yourself, is it benign or is it malignant, okay? It tends to have this leaf-like growth pattern on histology because of the stroma becomes quite proliferative to a point where it causes kind of this distortion to the ductal elements that gives it this leaf-like appearance. Now, malignant forms do occur, and that's really defined by what's going on in the stroma. The epithelium in every type of Phyllodes tumor, whether it's benign or malignant, is always benign. The malignant characteristic of a malignant Phyllodes tumor is defined by what happens in the stromal component. The stroma kind of becomes like a sarcoma. It will show increased cellularity, mitoses, cellular anaplasia. So here's an example of Phyllodes tumor. It's larger, so this is a larger excision of breast tissue. You notice the black here, that's ink. Whenever we get a breast resection of any sort, whether it's a biopsy or a lumpectomy or a mastectomy, the first thing we do before cutting into it is ink the margins with black ink usually, or other ink if needed. And that's because if there happens to be a malignant tumor there, we need to tell the surgeon how close it goes to the margin, and how can we tell that without inking it, right? And ink shows up on the glass slide, okay, on the histology section. That will help us determine the margin status. Now notice this Phyllodes tumor has a little bit of a softer appearance to it. In other words, it looks almost a little bit gelatinous, but not quite, but it's not as firm and fibrous looking like a fibroadenoma. But here's what it can do on histology. This is a benign one. Again, you see, well, where's all of this here is the epithelial component right here. And then you see all the stroma. There's such an overgrowth of the stroma here, and you get these like little projections that give it, if you look at the whole edge of it, it kind of looks like the edge of a leaf. That's actually where the term Phyllodes comes from. It means leaf-like pattern. Phyllodes is a Greek word for leaf. Now this is a benign one because the stroma is benign, okay? Here's a malignant one. Now here the epithelium is completely benign. This is a duct in here, kind of sitting in the middle of all this malignant stroma. And here the cells have become, they've become large, anaplastic, pleomorphic. There's nucleoli, there's nuclear atypia, there's increased mitotic activity. All of that you kind of see in a sarcoma. Now what about intraductal papilloma? That's the other kind of benign lesion. And basically what happens here is you get a papillary growth within a duct, which can become so large that it forms a cyst, or you'll have the papillary growth within a cyst. These are usually solitary lesions, and they commonly will cause, clinically, either a bloody or a serous nipple discharge. So when a patient gets a nipple discharge, especially in their 40s or 50s, one of the things they think about is the possibility of a papilloma, especially when it's bloody. I'm sure you'll see that again. You need to, bloody discharge, think papilloma, all right? And what happens though, the papillary, these papillomas are composed of papillary projections of epithelium, and they can become quite complex and also atypical, and in some patients they can be malignant. So you have to, obviously a papilloma is always benign, but there are forms that can be atypical and have malignancy associated with them. But when you see papilloma, that's a benign papillary lesion. If you see papillary carcinoma, then you're dealing with something else, okay? All right, so this is an example on histology of an intraductal papilloma. Again, they tend to occur in the larger lactiferous ducts, so you tend to see them in the subareolar regions, near the nipple, near the areola. This is a fairly large one. It's present within a dilated cystic space, and you can see this is just very complex papillary architecture. But the key to calling it benign is looking at it closer to see that the epithelial cells lining it are benign and that there are myoepithelial cells present. Because if myoepithelial cells are not present, that makes me worry about something malignant. That's why that's an important finding. All right, so here's an example on higher power of one of these this is what we're looking at. If we look here, we're going to look at one of these little branched structures here of epithelium. And this is what it looks like on higher power. And what is this? A classic papillary architecture, right? You've got your fibrovascular core lined by epithelial cells, which can sometimes be a little bit hyperplastic. But again, there's not more than 2 layers thick here, or 2 or 3 layers thick here of epithelial cells, and there are myoepithelial cells present as well. And so those are all good benign features, and so this was, consistent with a intraductal papilloma. The other thing is, if you were to see epithelial cells invading into the stroma here, that would also be another feature of cancer, okay? And I haven't gone into that yet, but that's another feature of cancer, but it's not, we don't see that here. All right, so speaking of cancer, all right, so this is a time cover from, guess what? 1991. Okay, that's when the first Gulf War started, okay? That's why you see that up there. But this was actually, there's actually another time cover I have, and I think they're due for another one now. But about every 10 years they come out with a new one for breast cancer. But when this came out, it was just to highlight the fact that, in fact, this number has actually gotten smaller now. It's more like 1 in 8. I don't know if you know that or not, but it's actually very common. Breast cancer is very common. They were showing some different imaging studies that they were trying to study. This is more like a thermal type study. They don't do this now. They do, the mammography has gotten really good. It's now digitized, and so it's very accurate now, much better than it was 30 years ago. Now MRI is used for imaging of high-risk individuals. You've heard of the BRAC, right? The BRAC, patients who have a BRAC mutation in their families, or they have it personally. Probably the best way to follow them is with MRIs. So MRIs are not done routinely for screening purposes, but because mammography has gotten so good with its digitization that it's really, that and ultrasound is needed too. But they don't do these thermal studies anymore. Okay, so breast cancer. Single most common cancer diagnosed in the United States women. Second most common cause of cancer-related deaths in women. What's the first most common cause of cancer-related deaths in women? What? No. What is the most common cause of cancer-related deaths in women? It's the same thing as for men. Lung. That's right. Unfortunately, yes. Lung cancer still. You see, the thing is, breast cancer may be more common, but I think lung cancer is starting to catch up too in women. But I think breast cancer, breast cancer is more common than lung cancer, but the incidence of lung cancer is also increasing in women. But breast cancer is still more common as a cancer diagnosed in all women. But because breast cancer generally has a better prognosis, thank goodness, okay, and lung cancer does not, lung cancer causes more deaths. Now, what are the risk factors for breast cancer? Well, just being a woman, okay, and the older you are, too, as a woman. Family history is important, especially if you have the history of the BRCA genetic mutations, either type 1 or type 2 is very important. Patients who have that mutation generally develop breast cancer at a very young age. Early menarche, late menopause is, again, what that tells you is that there's more hormonal exposure throughout your lifetime when you start early menarche and have later menopause. Nulliparous women. For some reason, women who never have children, that's what nulliparous means, never are pregnant is basically what it means, um, are at a higher risk. Apparently, pregnancy um, has a protective effect because it kind of removes a woman from that hormonal exposure for a period of time. Women who are obese, and that's true for a number of cancers, not just breast cancer, and patients who have a previous breast or endometrial cancer are higher risk for breast cancer. So here's the latest ACS, American Cancer Society statistics for both men and women. You've probably seen this before, but again, you notice how breast is right up on top here for women, and lung really about half that incidence. So I don't think that's going to change anytime soon. And of course, number 3 is colon, whereas in males it's prostate, lung, and colorectal. Ovarian only affects 3% of women, but ovarian is probably number 5, and number 5 in deaths. That it can, because it's obviously it has not as good a prognosis as some of the other cancers. This is again showing the cancer incidence rates among different ages or it's age adjusted, I'm sorry, among the different years to show you how it has changed over the years. This is men, this is women. And again, breast cancer has increased in frequency since 1975. It's actually starting to decrease now a little bit, as you see here. And I think really that has a lot to do with the screening that's done, because when you do the screening mammography, it can detect some of those lesions that may put a woman at increased risk. And when you detect them and are able to treat them, then you tend to remove some of those risks. But again, notice how lung has increased over the years, which isn't surprising. It's kind of plateaued as well. Colorectal has decreased over the years, but again, that's because of good screening with colonoscopy and so forth. Again, cancer, this is just a higher power of that same chart. And this is men. Again, prostate peaked at this time, but it's actually falling in incidence now. Lung is actually falling in men, which is a good thing. But I think it hasn't started falling in women yet. It's either plateaued or still goes up gradually. Again, chances of developing breast cancer by age, again, it increases the older you get. These are actually older numbers. It's actually it's closer to 1 in 8 for all. When you look at all women, the incidence may be 1 in 8. The highest incidence is 50 to 59-year-old women. For some reason, and I can't explain why, carcinoma tend to occur more commonly in the left breast. Now again, by just a small percentage, but just one of those things. Okay, they tend to occur more commonly in the upper outer quadrants of the breast. We divide the breast into 4 quadrants. Kind of looking at it like if you divide it into 4 quadrants, you got your upper outer, your upper inner, your lower inner, and then your lower outer, kind of going in a clock face direction. There's more breast tissue in the upper outer quadrant, and so that's probably why cancers tend to occur in that location. They can occur in the subareolar region as well, but not as commonly as in the upper outer quadrant of both breasts. These are all the major types of breast cancer histologically. Now again, you can think of breast cancer, you can divide it into ductal forms and lobular forms, or variants of ductal, basically. What you see here, and then the other thing is you can have both in situ and invasive forms of both those types. Okay, so you've got your main types there, ductal, lobular. You got variants of ductal, and then with each of those main categories, you can have both in situ and invasive forms. Okay, now here I show you there's ductal carcinoma in situ, also known as intraductal carcinoma. You can have lobular carcinoma in situ. You can have invasive ductal carcinoma, invasive lobular carcinoma, and then you can have all these others. And most of these others here are just variants of ductal, basically. They're different variants of ductal, but you need to be aware of some of their peculiarities because they look different on histology and cytology. Mets can occur to the breast, but it's very rare. Sarcomas can occur, again, very rare. Think of, cancers are going to be the most common and most commonly primary. All right, so what we're going to do is begin with the ductal varieties first. Actually, with the in situ varieties first. Okay, we're going to look at the intraductal carcinoma, also known as ductal carcinoma in situ, and then lobular carcinoma in situ. Now, ductal carcinoma in situ is most common in the 5th decade. Again, I told you that breast cancer is common in the 6th decade, 50 to 59-year-old, that's 6th decade. But the in situ, and that's encompassing all types of in situ and invasive cancers. But the in situ ones tend to occur a little bit earlier, a little like a decade earlier. And the only way to diagnose them, really, besides getting a tissue biopsy, but the only way they're found is on mammography. Because in situ lesions don't usually present as a palpable mass. They are picked up by what's done on mammography. And most often, that's looking for suspicious calcifications or slightly suspicious, what they call density on mammography. So you look for abnormal calcifications. On histology, it shows up as a very atypical proliferation of ductal epithelium that fills and plugs a duct, but it doesn't invade outside the duct. The duct may be large and very dilated and filled with epithelium, but it still has its myoepithelial layer surrounding it, and there's no invasion into the adjacent tissue. Okay, it's all in situ. Now, sometimes the tumor will have dilated ducts within it, in the duct, so you get these dilated spaces within a duct, okay, but it's all tumor still. There is a variety of ductal carcinoma in situ called the comitocarcinoma. You'll hear about that again, I'm sure, where the reason it's called comito is because it tends to have some necrosis associated with it. What happens when these ducts have this malignant epithelium proliferating within the duct is it can become necrotic and degenerated and very atypical. Usually the epithelium in comitocarcinoma is very atypical, very anaplastic looking. And then they get this necrosis associated within the center of the duct. And that's what causes it to have this comito pattern because of all the necrosis. Now the cribriform pattern is what you see where you get tiny spaces within a malignant duct. It gives it kind of a cookie cutter appearance, and that's called the cribriform pattern. It's most often the pattern we see with low-grade ductal carcinoma in situ, whereas the comitocarcinoma is a high-grade ductal carcinoma in situ. And you'll see examples of that in just a moment. All right, so I told you about mammography. Here's a mammogram of a lateral aspect of the breast tissue, and you can see the rib cage here and the pectoralis muscle here. Here's the breast tissue, here's the nipple. Now the normal breast tissue always has these kind of fibrous strands going throughout. Remember, it has fiber connective tissue throughout the breast, so that it shows up as these kind of white strands that you see here. That's normal. That's a normal breast parenchyma. But what's abnormal here is what's right here. I know, this is really subtle. Thank goodness radiologists are trained to pick this up, right? Okay. But you see this area here. This is actually a little area of scattered, punctate, small calcifications. The little white dots here, those represent calcifications. They're not normally like that. So that raises a suspicion. So what happens to this patient? When the radiologist finds this, they do some additional compressed images and larger images to try and bring out that area a little bit better. And then what they do, if it's not palpable, they recommend what's called a stereotactic core needle biopsy, which is they use the mammography machine to help guide the needle into the area and get little core biopsies of this. Okay, and that's how we get these samples most often is by core biopsies. And this is what we look for on histology. This is one example of DCIS. which stands for ductal carcinoma in situ. I like to abbreviate it DCIS. And you can see that this is one duct here, this is one duct here, this is a normal duct here. For contrast, this is a normal benign duct right here. But these are not. These are both, and so is this. All three of those are malignant ducts. And I know you're thinking to yourself, how can you tell that from the hyperplasia we saw earlier? Okay, it looks similar, right? Well, that's when you become a pathologist. No, I'm just kidding. No. Probably the easiest answer, no, I'm just really, there's actually ways to tell apart. The cells actually look more uniform. They don't have myoepithelial cells in here. They lose that component. They have these cookie cutter spaces like this. That's the cribriform pattern. And those are all features, in addition to some of the individual cytologic atypia, that would then support a malignant diagnosis over a benign one. Okay? So this has all those features. And again, very expanded ducts with these cookie cutter-like spaces. But guess what this is here? What is that? There and there. What's that? Well, necrosis can lead up to that, but there is no necrosis here. This is just calcifications. This is what shows up as those punctate little dots on the mammogram that we saw before that, right there, right there. Okay, that's what these little calcifications that you can see that are very dark purple here are what show up on mammography as those white densities on mammogram. So the reason there are calcifications there is because of the cells having undergone increased proliferation and turnover and degeneration. And what happens when that happens? That you get some calcifications. So, all right, so here's another one with this cribriform, very nice cribriform pattern. Here's a normal duct here for comparison. This is this whole thing is one neoplastic duct with this nice cribriform pattern with an area of some central necrosis as well. But again, this is another example of DCIS. Now notice it hasn't gone out into the stroma. It's not invasive. It's an important distinction because DCIS and invasive carcinoma have different treatments and different prognosis altogether. Here's another example of DCIS on high power, showing you the cribriform spaces with the very monotonous appearing ductal cells that are larger than normal with minimal atypia. So this is actually a low-grade DCIS. You don't need to know that, but from the I would have to know that when I'm signing it out, but it's a low-grade DCIS. Now, in contrast to low-grade, here's a high-grade DCIS, okay? Now, again, you've got this ducts that are quite expanded and partially filled with very anaplastic-looking malignant epithelial cells with lots of central necrosis. And that's what we're seeing here. This is actually an example of that cometocarcinoma variant, where you get all that central necrosis that forms this quote-unquote cheesy material when you cut, on section, but that's because of all the central necrosis, but that's what gives it its name, cometocarcinoma. Cometocarcinoma is always an in situ type of ductal carcinoma, and it's always a high-grade type of in situ ductal carcinoma. And what happens in the necrosis is you often get calcifications in it too. So here's one duct filled with all these filled with all these anaplastic malignant ductal cells, a lot of necrosis in the center and calcifications. The necrosis is the pink, the calcifications is the purple, okay? And that happens because of all the necrosis. And so you'll see on imaging studies, you'll see all these calcifications. It's very common. But unlike some of the other ones I showed you earlier, the cells here are much more cytologically atypical and anaplastic looking, and that's what makes it high grade. Another example with, again, large duct filled with both tumor cells and abundant necrosis as well as calcifications. And again, the distinction from invasion is the fact that it's remaining confined within the duct. There's no invasion into the surrounding stroma. And that's a very important distinction. Now, what about lobular carcinoma in situ, or LCIS? Sometimes you'll see in the books that they lump this into lobular neoplasia, but the better term nowadays is LCIS. It's often an incidental finding. You're biopsying the patient for fibrocystic change, suspected fibrocystic change, or You find sclerosing adenosis, and oh, by the way, the duct next to it shows lobular carcinoma in situ, okay? It doesn't cause a palpable mass. It may not even show calcifications. So it's really very challenging sometimes to find this lesion. But like I said, it usually occurs in the setting of something else. Now, how do we define this and distinguish this from atypical lobular hyperplasia? Well, what happens is that the terminal ducts and the acinar units, at least 50% of them within a given lobule, need to show a proliferation of this very monomorphous lobular type cell. And I'm referring to the type of cell that normally lines either the terminal duct or the acinar units. And the lobular proliferations are loosely cohesive, larger than normal, with rare mitotic figures, and round to oval, very uniform appearing nuclei. So actually these cells look very monotonous, and they have very little nuclear atypia. But the important thing is the architecture. Like right here, here's a lobule. I showed you lobules before, and you can see it's quite expanded. First of all, there's a lot more of these individual acinar units, and each of the acinar units are filled with these monotonous cells that we refer, and again, and at least 50% of them are involved with this proliferation. So this was an example of lobular carcinoma in situ. In fact, what's even happened here is that the neoplastic lobular cells are expanding into the adjacent duct and going outside but remaining confined within the duct. We call that actually lobular extension into the ductular units. But you see, it's still remaining confined within this whole lobule. It's not even going out of the individual acinar units. So there's no invasion, so it's in situ. Here's another example. Again, notice the acinar units within a given lobule are expanded by this uniform proliferation of monotonous small cells, relatively small cells. So it's really the architecture that's very key here to the diagnosis of LCIS. All right, so now we're going on to invasive cancers, and the most common of these is invasive ductal carcinoma, representing anywhere from 75 to 80% of all the invasive breast cancers. Now, the tumor tends to form a very dense fibrous stroma with a very hard consistency. So these lesions, when they're of certain sizes, if they're really tiny, they're not going to be palpable. But once they get to a certain size, they usually cause palpable masses in the breast. Histologically, they're like any invasive cancer you've seen anywhere else so far. You've got malignant glandular cells invading the stroma, okay, right? That's basically what it is. Anaplastic ductal cells, which are glandular cells consisting of invasive solid nests of cells, either, so you have these invasive nests as well as tubules or other glandular formations, including papillae. Now, cytologically, the tumor cells can vary from small to large, depending on the grade of the tumor. Okay, low-grade tumors tend to have smaller, more monotonous appearing cells. Higher grade tumors have more anaplasia. This is true for any tumor else, invasive tumor anywhere else. Okay, so let's look at this mammogram. Here's another lateral view. You've got the chest wall here. You got the nipple here. Now you got this, and you got other breast parenchyma here that's fairly normal, although it does have some dense appearance to it. And then you have this little marker here. Now this marker was put here because the patient said she palpated something over that area, okay? So what they do is the patient comes in and then she tells the mammography tech or radiologist, I palpate something there. They're going to put a marker over on the skin, so it will kind of highlight that area on the mammogram. And so if you look near that marker, you see, oh, lo and behold, what's that? You see how it stands out differently from the rest of the breast tissue? It's like a very kind of a solid area of density. They call it density. No calcifications, but you can have them. But there's definitely this irregular density with this kind of what we call stellate border. Those are all characteristic words. So if you hear those words, you got to think, oh my gosh, that's very suspicious on mammography for breast cancer. And a lesion like this is breast cancer or invasive breast cancer until proven otherwise. And so it gets biopsied. This is a large biopsy. Okay. Like, they're still going to, the radiologists are still going to do a core biopsy of this because they do a core biopsy of all breast lesions now, okay? But if it's palpable, they may not need to do it by stereotactic means. They may use ultrasound or, or even just palpation to get to the lesion depending on how big it is. But this is actually a mastectomy specimen, a section from a mastectomy specimen, just to show you how invasive carcinoma can look like on gross exam. Here's the ink. I tell you, we always ink the margins, and so this is the deep margin inked. Here's normal breast tissue over here and up here, but this is the breast cancer right here. See how it stands out differently than the surrounding breast parenchyma. It's whiter because of all the scar tissue. It's very firm. When you feel this on exam, it feels very rock hard because of all the desmoplasia of the tumor. And here's what it looks like on histology. It looks just like any other invasive cancer that you've seen already with glandular elements, okay? And so you've got invasive nests of malignant cells invading nests as well as tubules and acinar structures that are invading haphazardly throughout a very scarred desmoplastic stroma that you see surrounding each of these nests. Here's another example where you see mostly flat, solid nests of invasive carcinoma. So these are all malignant nests of ductal epithelial cells surrounded by very dense stroma. And that's about it for invasive ductal. That's the very characteristic appearances. Invasive lobular is a little bit different. Okay, now again, this means that the tumor is arising from those lobular units, lobular areas, because ductal most often arises from the ducts. Makes sense, right? Okay, now invasive lobulars are not as common. They only represent about 5 to 10% of invasive breast cancers. They can occur bilaterally. So sometimes when they find one lesion on one side of the breast, they may make sure they look closer at the other side at the same area. They can be multicentric, meaning that they can occur in multiple areas of the same breast. They're often very poorly circumscribed and rubbery, not discrete and hard like ductal carcinomas. They don't cause the same amount of serous changes to the stromal tissue. But one of the characteristic findings is that the tumors tend to infiltrate in single cells in the stroma. The single cell filing we've kind of referred to in the past as Indian filing, which is, we're not supposed to use that term now, but that's exactly what it's called. It's a single file of tumor cells within the fibrous matrix. And the cells actually tend to be very small and uniform with little pleomorphism, which is unlike ductal carcinoma. And you're going to see that in CYTO too. All right, so here's an example of invasive lobular carcinoma. And look at here. This is one of the features we see in invasive lobular. It tends to go around ductal elements in this kind of circle-like fashion, and it's kind of like you see here this normal duct right here. It's a little bit. This is actually a normal duct. It's a little bit dilated, but it's a larger duct. There's a little bit of inflammatory cells. Those are lymphocytes here. But the tumor cells are all of this right here. So you see this kind of concentric arrangement of tumor cells invading the stroma around this normal duct. And that's a very characteristic finding of lobular carcinoma. And usually the nests are only 1 to 2 cells thick, usually. Here's another example of this single filing within the stroma. This is normal stroma, the pink. Here's the tumor cells kind of invading in this single file throughout the stroma. These are malignant cells. They're round to oval nuclei. Some have vacuoles, targetoid vacuoles in their cytoplasm. Sometimes it looks like they mold against each other, and it can sometimes resemble small cell carcinoma. And you'll see that on cytology too, but it's not. Because does small cell carcinoma have vacuoles in their cytoplasm? Not usually. But again, the molding you can see sometimes kind of resembles that. All right, so now we want to look at a few variants of other types of invasive carcinomas. All of them are not very common, but medullary and colloid and Paget's and inflammatory carcinomas are all basically variants of invasive ductal carcinoma, just different types of things, and they have different appearances sometimes, but they all arise from the duct, just like, your invasive ductal carcinoma, NOS. Medullary is very rare. I have to tell you, I don't recall the last time I saw one. Okay, and part of it is because we're kind of lumping them all into, tending to be a little bit more general in our diagnoses. Okay, but it is important to recognize this entity because it tends to present with a different clinical appearance and a different histologic appearance and a different cytologic appearance. So you'll see that later on. It tends to cause, instead of a rock hard mass on palpation, it causes a large fleshy soft tumor. And they're soft because there's not as much desmoplasia. What you see instead of the fibrous tissue in the stroma is lymphocytes. Okay, so this is a type of tumor that will have fairly discrete borders, have a soft appearance, will have the malignant epithelial component surrounded by lymphocytes that are benign. Okay, it's just the lymphocytes are kind of there for the ride, all right, but there's a lot of them. So remember that. The characteristic findings, because you're going to see this on CYTO too, syncytial groups of malignant epithelial cells that are quite large, with pleomorphic nuclei, lots of mitoses, that are surrounded by this very pronounced lymphocytic infiltrate between the syncytial sheets. All right, so here's an example. Now again, it's hard to actually make out even the malignant component here, but it's here, right here. You see all these, this component is, all of this here is the malignant epithelial component, these syncytial nests of very large pleomorphic cells with abundant cytoplasm, often with very large vesicular nuclei. And in between each of these nests, instead of a lot of fibrous tissue, you see mostly lymphocytes. Here's in a higher power view to show you these malignant ductal cells that have very large vesicular nuclei, often abundant to very pale cytoplasm, and then lymphocytes, benign lymphocytes, throughout, many of them throughout the stroma. You don't see that with any of the other tumors, so it's a kind of a unique pattern. Now, this isn't in your handout, but I think it's in your CYTO. It's not on your pathology one, but it's in your CYTO one. You'll see tomorrow. But the tubular carcinoma is just a variant of ductal carcinoma. It's very low grade that forms well-defined tubules on its histology. Okay, and that's what we see here. You see this and you look at it. Is this really cancer? I mean, really. This is probably one of the more common reasons for a false negative pathology diagnosis on pathology, okay, or CYTO, because it looks so bland. But after you look at it for a while, you realize that these ducts that are small and regular, and sometimes forming these little tubular structures like you see here, are invading in a haphazard fashion in the stroma, okay? But the ducts are still lined by atypical cells that are very low grade, so again, it makes it very hard. There's just too many of them, and and the other thing is no myoeps, okay? So you'll see there's no myoeps surrounding these ducts, and that's a bad thing. Tubular carcinoma. Okay, colloid carcinoma is another usually low-grade variant of ductal carcinoma that, in addition to the invasive ductal component, has all this mucinous material in the stroma. Okay, so just like colloid carcinoma in the colon, you've already done that, right, GI? It's going to be the same thing in the breast. You'll get these large pools of mucin with scattered nests of malignant epithelial cells. And the mucin, it can be really quite pronounced. And it can make the tumors feel, because of all that mucin, it feels soft. Just like the medullaries, it can have this kind of gelatinous, soft appearance to it. But what do we see on histology? Well, we see all this mucinous material, which, oh, by the way, the mucin tends to wash out during formalin processing. So you're just going to, oftentimes you're going to see these large empty spaces where the mucin used to be. Now, you're actually going to see more mucin on cytology, okay, than you do on histology, when you avoid that, when you have your direct smears and you don't have to have it exposed to formalin. But the again, this is just large spaces here that used to be filled with mucin. Now there's still some remaining mucin, but usually not a whole lot. But you get these large spaces with these little acinar formations, other glandular formations of fairly bland-looking malignant ductal cells, kind of either embedded within the colloid or out to the periphery, kind of hanging out to the periphery there. But again, the key is to calling it malignant is not the mucinous component, but looking at the individual epithelial cells. Here's another example, but this is on CYTO, where you actually can see the mucin. And again, the mucin itself is a benign component. It's the cells that you have to look at to call it malignant. But when you don't normally see this much mucin on any breast FNA. If you see this much mucin, it should be a clue to make sure you're not missing something. But you know mucin stains very metachromatic on dipquick, like you see here. And then, of course, a light green to blue on pap stain, as you see here. And there's lots of it. And embedded within the mucin and also separate from the mucin are these groups of malignant ductal cells that you see here. We have groups as well as single cells that have anaplastic features. All right, what about Paget's disease? Paget's disease occurs on the nipple, and it usually occurs in the association with a ductal carcinoma occurring elsewhere in the breast. Okay, it's not usually occurring by itself. So if you find Paget's disease on the nipple, it's important to look for the main tumor mass somewhere else in the breast. And it can be either in situ or invasive ductal carcinoma occurring elsewhere in the breast. So what's happened here is that the malignant ductal cells have basically found their way to the nipple, okay, through the ductal system, and have kind of set up shop there, okay. And what happens, though, is that the Paget's disease can cause what looks like an eczematous appearance to the nipple and to the surrounding skin, because it can involve the adjacent skin as well. Now, the malignant cells that are seen, just like in the vulva, are referred to as Paget cells. And they are very large malignant anaplastic cells occurring within the epidermis, kind of scattered in the epidermis. And we confirm that they are Paget cells with special stains to include positive stains for mucin, EMA, CEA, estrogen receptors. Okay. And like I said, it's invariably associated with another tumor elsewhere, like a DCIS or invasive ductal carcinoma arising deeper in the breast. So when a patient presents with this kind of chronic inflammation or eczematous reaction on the nipple, usually the surgeons are going to not only biopsy the nipple or the areola, but they're also then going to set up the patient for additional studies. So look for the tumor elsewhere in the breast so they can get a biopsy of that area as well, because that's what's going to determine the type of treatment and prognosis overall. All right, so here's an example from some pictures from Netter. This is the eczematous type where the nipple just appears eroded and irregular. Here it's very ulcerated as well. And then here's what it looks like on histology, where you can see the Paget cells that are large, vacuolated, pale, malignant cells kind of scattered throughout the epidermis of the overlying epithelium of this nipple or the areola. And then here's the adjacent breast cancer, okay? And basically what has happened is that those tumor cells have kind of migrated along the duct system to involve the nipple. That doesn't happen in all breast cancers, and it's important to recognize, though. Here's a very bad example. I mean, gosh, look at that. It's horrible. And you're thinking, this didn't develop overnight, okay? This was there for a long time before it got that bad. And you have to think to yourself, why did this patient not go see the doctor? But that happens. Patients sometimes they're in this horrible state of denial, or they're so afraid to go see a doctor, or embarrassed, or whatever, that they just kind of let it go. Or they have other medical issues or something, and who knows why they don't go seek the help when it could have been, addressed before it got this bad. But here are the Paget cells in the epidermis, these larger pale cells here. Okay, the last of these variants I wanted to talk about is inflammatory breast cancer, and it's really kind of a misnomer because it doesn't mean the breast cancer is inflamed. What it really means is the clinical appearance of this type of cancer. What happens is this ductal carcinoma, which it usually is, spreads into the lymphatics so much so that it involves the superficial lymphatics of the dermis of the entire breast, and it causes the entire breast to look inflamed because of that, because of the lymphatics being filled with these tumor cells. It's not really an infection type of inflammation. It's kind of like lymphatics are filled, making the breast look inflamed, kind of red and pitted and swollen. But it's really bad when a patient presents with inflammatory breast cancer. It's usually a stage 4 tumor, and the prognosis is not very good. 5-year survival is less than 5% when patients present with this form of cancer of the breast. And so this is what it can look like when it gets so bad. The whole breast looks red, inflamed. You notice how because of the swelling in the skin, and it's really because of swelling in the skin, it often gives it a pitted look, and it's referred to because of that pitting, because of the edema. It's called peau d'orange, which means orange peel-like. Okay, peau d'orange is French for orange peel, and that's what it kind of looks like, an orange peel in some cases because of all the pitting from the edema, basically. And here is what it looks like on histology. Here's the skin. And so you could biopsy anywhere on this breast here, right here, and see this involvement of this. And so you have to take a biopsy of the skin to be able to diagnose this. And when you biopsy the skin, here's the normal epidermis. And in the dermis, immediately beneath the epidermis, are these lymphatics that are filled with tumor cells. And now this is coming from a tumor mass elsewhere in the breast. Okay. All right, rare or unusual malignant tumors. Again, malignant tumors can arise from any part of the breast tissue, some from the connective tissue, from the fatty elements, from lymphoid elements. Very, very rare to see that, but it can happen. Mets can occur to the breast, and the most common metastatic tumor involving breast are melanoma, lung, ovary, sarcoma, GI, and urinary tract lesions in roughly that order, melanoma being the most common. In men, guess what? Prostate cancer is most commonly involving the nipple and areolar area when there is a metastatic lesion there. And speaking of males, we do have to talk about a couple things with the males in breast. Gynecomastia is a common benign problem of the male breast. It's generally enlargement of the male breast due to some hormonal influences. It can be unilateral or bilateral. And it usually occurs in the setting of increased estrogen levels, which can occur in conditions affecting males such as liver cirrhosis, Klinefelter syndrome, certain types of testicular drugs, and certain drugs can cause that. During puberty and adolescence, young men sometimes have some increased estrogen levels circulating in addition to the testosterone, and that's why you sometimes see this occurring in young adolescent males. Again, it can be either unilateral or bilateral, causes a button-like subareolar enlargement, and it's due to proliferation of the ductal elements, because guess what? Men don't have lobules, right? We talked about that earlier. So you get hyperplasia of the ductal epithelial lining associated with some dense fibrostroma, and it looks exactly like a fibroadenoma does in a woman. It really does. On both histology and cytology, you have this proliferation of the ductal elements and proliferation of the fibrostroma. And here's what it looks like on histology. And you've got these ductal elements surrounded by this kind of mix. It's a little mixoid here, meaning it's got a little bit of fluid there. Mixoid stromal components surrounding those proliferated ductal elements. But it's all benign. But I do want you to know that men can get breast cancer too. I mean, there are ducts there. Obviously, it's not as common as women. The ratio is about 1 to 100, but it does occur. I've seen several examples throughout my career of male breast cancer. It tends to be older men, and obviously the most common type is going to be infiltrating ductal or invasive ductal carcinoma, because they don't get invasive lobular carcinoma. They don't have lobules. But it's treated exactly the same as women. It has similar histologic and prognostic features as in women. So here's an example of an invasive ductal carcinoma occurring in a male breast. It generally presents as a hard, firm nodule in the subareolar region. All right, now we're going to talk a little bit about some of the prognostic features and some of the treatments and staging, just so you have a little bit of understanding of this, because this is very important to what we do in pathology and cytology for treating patients with breast cancer. Probably the most important thing, besides actually looking at the tumor itself to diagnose it as cancer, and once we have diagnosed cancer, the most important thing for prognosis is, what does the axillary lymph nodes look like? Are they involved? Are there mets to the axillary nodes? And obviously we base tumor staging on both the tumor size as well as the axillary node status, as well as some other things, or if there's distant mets. You know, obviously anytime a patient with breast cancer, thankfully it doesn't happen this way very often. You know, if someone with breast cancer presents with distant mets, it's already a stage 4, just like other cancers. But when we look at a breast cancer, we type the histology. We always do hormonal receptors on the tissue, which includes ER and PR and HER2/neu. And HER2/neu is done by both IC, immunohistochemistry, as well as FISH analysis. If it was kind of indeterminate on IHC, then they automatically default to doing FISH analysis for the HER2, because HER2 is very important nowadays. In fact, if you read the news the other day, there was a new drug that just came out for treatment of HER2, new positive patients. There's already at least 2 already, I think. I know of 1 already for sure. Herceptin, you've heard of Herceptin maybe? That's used for treatment, but only if you're HER2 positive. So that's why it's important to do the HER2 analysis. But now there's this new drug, I forget what it's called, that they've tested that's also effective in HER2 patients. But the one thing we have found, or many oncologists have learned, is that patients with HER2 positive tumors generally have a worse prognosis than those without. So it's actually, if you get a tumor with HER2 status positivity, which is probably about 10% of the cases I see, okay, it generally means a worse prognosis for the patient. But on the other side, it's potentially a good thing, because there's actually drugs out there that can target tumors that are HER2 positive. So it's very helpful for the overall treatment and prognosis of the patients. We don't do much with the tumor proliferation activity anymore, but just to be aware of that. I mean, really the best thing is the hormonal status, and of course knowing the axillary node status. So here's some examples. This is actually, if you can tell, I know you're not going to be able to, it actually used to be a lymph node, okay? You haven't done lymphoid stuff yet, have you? No, okay. All right, so this used to be a lymph node. You see a little residual lymphoid tissue out here right at the edge, but the rest of it is nearly completely replaced by metastatic carcinoma from the breast, okay? So this is all ductal carcinoma that has metastasized to this lymph node. This is a more subtle example, and this sometimes happens with lobular. You notice here's a lymph node. This whole thing here is part of a lymph node. This is the capsule of the lymph node. This is the surrounding fat, because lymph nodes are always in fat, okay? But this is the lymph node capsule. Here's the lymphoid tissue that looks benign here. If you look very closely, right here, see that right there to over here? This whole area right here, and then right here, in what's called the subcapsular sinus, has a little focus of metastatic lobular carcinoma. That's it, okay? That's a positive node. Now, it's considered a micrometastasis, and that's important to know, but it's still important to find that. Thankfully, we have immunostains to help us in this process sometimes. All right, and then I mentioned to you we always grade carcinomas. Well, moderate, poorly differentiated, or grade 1s, 2, and 3, just like any other tumor. So here's an example of a well-differentiated infiltrating ductal carcinoma. It most closely recapitulate what looks like normal ductal elements, except it's not. Okay, it's invading the stroma, and there's some atypia here, but not as much as you would see in a high-grade tumor. Here's a poorly, and in contrast to that, because you can see there's still nice glandular formation here, nice glandular lumina. I don't see any mitoses, and very minimal nuclear atypia. So all those features are taken into account when grading. Whereas in this one, you see no glandular formation. You see lots of mitoses. I can point out one here, one here, one here. You know, they're all over the place. And lots of nuclear atypia. So this is a poorly differentiated tumor. Now, like other tumors elsewhere, these tend to do worse, okay? These patients tend to do worse. Again, estrogen and progesterone receptor positivity is important. Patients, most tumors are ER and PR, most invasive and many in situ carcinomas are ER, PR positive, but some are negative, and that's important to know because these patients get treated with anti-estrogen therapy, tamoxifen. You've heard of tamoxifen? Okay, you don't treat a patient who's estrogen and progesterone receptor negative with tamoxifen because it's not going to be effective. Tamoxifen will only be effective for patients who have ER and PR positivity. So that's why it's important to do. And so this is a nuclear stain. And so what we're seeing here is nuclear staining indicating a positive result. All right, again, I mentioned to you breast cancer staging. There's stage 1 through 4. Stage 1 breast cancer is any tumor less than 2 centimeters in diameter. The tumor mass itself, the invasive tumor mass, is less than 2 centimeters in diameter, and there's no lymph node involvement and no distant mets. Stage 2 is a tumor that's larger. It's less than 5 centimeter with no, and again, if it's a tumor that's less than 5 centimeters with no distant mets, or a tumor greater than 5 centimeter without nodal involvement. So again, tumor that is somewhere between 2 and 5 centimeters, or is a tumor with positive breast nodes. It can be a tumor less than 2 centimeters with positive breast nodes, and that would be a stage 2. Okay, but if it's more than 5 centimeters without nodal involvement, it's still a stage 2. Does that make sense? Okay, so nodal involvement for 5 centimeter or less, or without nodal involvement for 5 centimeter or more. Now, tumors, very rarely, breast cancers are very rarely that large. Okay, that's unusual to be 5 centimeters, but we do see that. Most of the breast cancers we see are usually around 2 centimeters, 1.5 to 2 centimeters. You would like them to be smaller, obviously, but most of the ones we see are somewhere between 1 and 2 centimeters. And then again, it depends upon what their nodes are showing, whether they're stage 1 or stage 2. Now, stage 3 includes all breast cancers of any size that have skin involvement, pectoral wall or chest wall fixation, fixed nodal involvement, but no distant mets. And then, of course, stage 4 is any form of breast cancer. It can be 0.5 centimeters, okay? And if it has distant mets, it's a stage 4. All right, so how do we diagnose breast cancer? Well, we do so many different things. Now, we're not the ones doing the biopsies, except for the FNAs sometimes, okay? But all these other ones are usually done by radiologists or surgeons in general. We can do FNAs, but I have to tell you right now that FNAs, we don't do many breast FNAs anymore. We don't. I mean, it's important for you to know how to recognize the cytology of breast cytology, but be aware that, when I first started in pathology, in fact, I did a study in breast FNAs when I was at William Beaumont. And in 1 year, actually it was about over a year and a half, I did 250 breast FNAs. That was in I'm really going to show my age here now, right? That was in 1994, okay? I did almost 250 breast FNAs myself, okay, in 1 year. I'm lucky if I do 5 in 1 year now, okay? When I'm working, okay? When I was working, I'm lucky if I do 5, All right, it's really what's taken over the assessment of breast tissue is core biopsies that are done by the radiologists, usually through ultrasound guided techniques or stereotactic guided techniques. And that's not usually a procedure that we go on to support, like the other cores that the interventional radiologists do. This is one the radiologists normally do, typically in their the mammography suite, and they don't normally ask for our assistance unless they want to do some cytology touch parts, which isn't very often with these. They just send us the cores. So it's really and one of the reasons why they've shifted from FNA to these very modern stereotactic core needle biopsy methods is because on FNA, it's hard to distinguish invasive from in situ carcinoma on cytology. And that was one of the drawbacks with doing the FNA. And plus with the stereotactic means, it can help guide the needle. And that's important because the smaller lesions, you can't palpate them. So you have to have the needle to guide you, or the imager to help guide the needle location, which is key because you want to make sure you biopsy the right area. And so with the imaging necessity and the fact that it's hard to separate out invasive from in situ on cytology, most patients with an abnormal lesion in their breast are going to be assessed by stereotactic core needle biopsies nowadays. Excisional biopsies are done for things that are thought to be benign, like a fibroadenoma. Lumpectomies are done for breast cancers. For treatment, a conservative treatment of taking out just a small portion of the breast tissue. Nipple discharge smears can be done when a patient presents with discharge. Ductal lavage is very rarely done nowadays. It is still something you can pursue, but we don't do it very much in the military, I know that. So here's some fine needle aspirations are only done generally when we do them only on palpable lesions. If I can't palpate it, I am not sticking a needle in it. Okay, I got to be able to palpate it first. So here's an example of an FNA of a lesion. Here's a stereotactic core biopsy. But the key with these, and again, the needle is larger, and it's done with imager guidance. Here's an open biopsy, and here's a needle localized biopsy as well. Now, needle localized biopsies also use the stereotactic machine, but they localize the lesion with the needle, and then they send the patient to the radiologist to excise the tissue around the needle. So it's an excision, not just a biopsy, or a core biopsy, I should say. Here's an example of a ductal lavage where you actually aspirate one of the ducts to look for abnormal cells. And again, it involves, I don't think I'd like this as a patient. I don't know, sticking this device into a dilated nipple opening, it doesn't sound very palatable, Put me to sleep, no. But, again, you can, by putting fluid in there and aspirating it out, you can presumably, I've actually never, I only seen this in examples and study sets, not in actual life. I've never seen a case of this. But some places do them, and they find that it's helpful for assessing high-risk patients, like those with BRCA mutations, for instance. All right, so surgical treatment procedures can include lumpectomy, lymph node dissections, mastectomy. We already kind of talked about this. The lumpectomy is where they take out a small portion of the breast tissue, not even a whole quadrant, just a portion of a quadrant in some cases. Axillary lymph node dissection is where you dissect all the soft tissue out in the axilla to get at least 20 lymph nodes for assessment. But nowadays, what the surgeons are doing primarily in patients with a diagnosis of breast cancer is a sentinel lymph node biopsy where they isolate the first draining lymph node of the breast tissue to be able to see if it's involved. If it's positive, then they do the complete axillary node dissection. And then mastectomies can either be modified radical or radical, and modified radical is where you don't take the pectoralis or chest wall, whereas the radical is where you do. And they're really, I don't recall the last time ever getting a radical mastectomy, and modified radical mastectomies are still being done, but really to a lesser degree than lumpectomies. And so, again, this is now 10 years, 11 years later from the last time article that showed from February 2002, and it's talking about all the new drug treatments and other treatments that are available for patients with breast cancer, and there's quite a bit now. This is actually borrowed from that article. Again, you can do tumor ablation with radiofrequency probes that directly hit the tumor. Again, you use imagers to help you with that. You can do, this is showing you endoscopy of the milk ducts to look at the actual milk ducts. And here, through this type of device, you can do that ductal lavage. You can do targeted radiation with a balloon tip here. You can do molecular, they're doing this already, by the way, molecular forecasting, where you can take tumor cells and test their DNA to see to get an overall prognostic forecast for that patient. It is somewhat of a debatable thing to do, but they've actually found it helpful in certain patients, especially those who present with metastatic disease. And then, of course, the whole idea here is to try and, I'm not sure if as a patient, if you did this when you were first diagnosed with breast cancer, I'd really want to know if I'm going to present with metastatic disease in 3 or 4 years, I'm not sure I want to know that, I don't know, but it seems they find that if they know that and they find that the patient is at a higher risk because they have that possibility, then they can potentially treat them and follow them a little differently. So it can be helpful in the long run. There are smart drugs like Herceptin, which will attack the tumor cells that have that HER2 new positive protein. That's why we do that kind of testing. And again, the Herceptin can be helpful in those patients. And now there's this other new drug too. Now, be aware of the breast cancer screening guidelines. Mammograms recommended by the American Cancer Society, yearly mammograms starting at age 40. Clinical breast exams meaning breast exams done by a provider who's trained in doing breast exams. Usually recommended about every 3 years for women in their 20s and 30s, and every year for women 40 and over. Women obviously should report any breast change promptly to their healthcare providers. Breast self-exam is actually not touted as as much as it was a decade ago, because they have found that it really doesn't work that well. Women, don't do it. They don't know how to do it. They don't know really what, but I think it's still important. It is an option for women starting their 20s, and it's something I would always encourage a woman to do and to train them how to do on their own, because usually it is a woman who can sometimes detect the change initially. But I think probably what's made the biggest difference in screening for breast cancer is the mammograms. But again, not starting till age 40 unless they're at a high risk, unless they have a BRCA mutation or strong family history, may warrant starting screening earlier or having other tests like ultrasound, MRI, etc. And more frequent clinical breast exams. I know women who are BRCA positive who have to go in for exams every 6 months, who've had MRIs, and they're less than 40 years old. Some women you've probably seen in the news who have BRCA mutations opt to get bilateral mastectomies, prophylactic mastectomies, because that's how you can prevent from getting breast cancer. I know that seems like a drastic approach, but I've seen that happen, and I'm sure you've heard about it in the news too. But maybe they, those women, maybe they've had their children they wanted to have already, and they're not going to be nursing, and they're thinking, well, why should I keep these breasts that are just going to get breast cancer? Why? I mean, save your life. All right. And I forgot this picture was here, but I took this picture during the summertime in upstate New York. It's a place. Has anyone here ever been to upstate New York? Well, there's a very beautiful part of the country up there, if you've never been there, along the St. Lawrence River, the St. Lawrence Seaway, which includes the Great Lakes. There's the St. Lawrence River, goes from Lake Ontario to the ocean, and there's an area just beyond Lake Ontario that's called the Thousand Islands, and there's actually 1,800 islands there. I know, it's just an amazing part of the country during the summer. Right now, if I were to show you a picture from there right now, it would be covered with ice and snow, and not looking like a lot of fun unless you like to do ice fishing. But This is an island called Hart Island that has this castle on it. Was built in the late 1800s, early 1900s, called Bolt Castle by Mr. George Bolt, who used to be the owner of the Waldorf Astoria in New York City many moons ago. And a lot of folks from New York City during the summer used to come up on vacation by train. You know, they take train up to upstate New York, and he liked going up to the Thousand Islands with his wife and his children. And unfortunately, his wife passed away before this castle was entirely completed. They had the outside structure built entirely with all the rooms inside, but they never finished it, and they stopped all construction. But now it's a historical place to visit, and there's boat trips that go there all the time, and they're actually renovating all the rooms. It's really a fascinating place. It really is. It's very interesting to go see. And I enjoy it a lot. I go up every summer because my parents have a summer home up there in the Thousand Islands. And so I enjoy going up every summer. And every year I'll go and visit Boat Castle to see what new changes they've made. This was actually the playhouse for the kids. It includes a bowling alley. I mean, this is really, for early 1900s, okay, it's amazing. It is an amazing place, but it's a beautiful place. The whole Thousand Islands is about 30 miles long, and it's a beautiful place to visit. So if you're ever up in that upstate New York area, you ever get assigned to Walter Reed, you should definitely check it out during the summer. It's only a few hours drive. All right, any questions? That was a lot of information today, I know. Tomorrow, the breast cytology will kind of bring it all together. All right, so I'll see you tomorrow morning at 8:30. Should I stop it, or this one?